Yeah, thanks, Jody. Welcome, everyone. Today, we're fortunate to be hosting Dr. Dan Kinderlair again. And I want to thank our 2021 community partners for supporting the activities that help us bring these resources to you. Dr. Kinderlair is a nationally recognized physician with expertise in the fields of nutrition, allergy, environmental medicine, and Lyme disease, and in the healing of mind, body, spirit as a unified whole. He has an integrated medical practice in Denver, Colorado. We're lucky to have him here in our backyard, focusing on the diagnosis and treatment of tick-borne disease. He's the author of several review articles in medical journals, as well as the Lyme Times. He's also the author of a new book published this year, and I want to show you this. Recovery from Lyme Disease, the Integrative Guide to Diagnosing and Treating Tick-Borne Illness. The reason I want to share this is because whether you're new to Lyme disease or you're somebody that's been struggling for a long time, this book has so much valuable information, resources, and I highly recommend it. I blew through this book, and I know it's shocking, but I really did do it in 2 days. So it's a wonderful resource, not just the first time you read it, but to be able to go back to as well. Dr. Kinderlair provides support to patients in Colorado and beyond, and we can't thank him enough for his continued participation in and support of COTBD-AA. COTBD-AA and Colorado Lyme and Tick-Borne Disease Support Group are partnered together to bring you these resources. We will be recording today. However, we won't be able to post a link to the recording until after the new year. If you have any questions, please put them in chat. So when Dr. Kinderlair is done with his presentation, we will have a question and answer period. So with that, I'd really like to welcome Dr. Kinderlair as he speaks on microbes and mental illness, PANDAS, and tick-borne infection. Thank you, Dr. Kinderlair.
Thank you, Monica. I really appreciate all the work that you and Jody and others do, bringing awareness to what's going on here. So I want to particularly mention the importance of awareness of the psychiatric aspects of these infections. By themselves, they can be disabling and debilitating. And it's interesting that often it's psychiatrists and psychotherapists who make the diagnosis of Lyme disease after someone has seen a dozen internists, neurologists, rheumatologists, and so on. And what we're seeing now is this increasing incidence of PANDAS, and that's what we're going to be talking about today. So I am going to share my PowerPoint, and we will get started. Okay. This is what we're going to be talking about today. So I guess you need to fasten your seatbelts. We're covering a lot. We're going to start off with a few case histories, describe what PANDAS is, and then what PANDS is, the Cunningham Panel, tick-borne illness, psychiatric disorders, a pilot study that we did right here in Colorado, treatment for PANDS, and conclusions. Okay, case histories. We're going to start off. These are all people in Colorado. 14-year-old female, complaints since childhood include depression with dark intrusive thoughts, anxiety with phobias and panic attacks, OCD, constipation, enuresis, that's bedwetting, syncopal episodes, that's passing out, palpitations, sleep disorder, also drenching night sweats, chest pain, air hunger, muscle cramps, numbness, and paresthesias, which are pins and needles. So you out there who are already versed in chronic Lyme immediately recognize this as tick-borne infections. But you also are aware of what happens if someone like this goes to mainstream medical doctors. This is considered a psychiatric problem. But I also want to mention a couple things here. Constipation and enuresis. These are common symptoms of food allergies, food sensitivities in children. And that often is wrapped up in this. Night sweats, chest pain, air hunger, those of you literate in Lyme already know this person's got babesia, right? Okay, on physical exam was remarkable for POTS, that's postural orthostatic tachycardia syndrome, a manifestation of dysautonomia, in which people stand up and suddenly their pulse skyrockets and they often get lightheaded, sometimes even passing out. She had prominent stria. These are red lines, which I will show you on her legs, arms, and breasts. And we see them with Bartonella infection. I'm going to be talking a lot more about Bartonella. She had some impaired cognition. Her laboratory was significant. She did have positive Lyme serology, that's Lyme antibodies. She also had positive babesia antibodies, which we already knew by taking a history. And she had an IgG RAS to multiple foods that were positive. She was sensitive to a lot of foods, which is more common than not in this situation. Here is a picture of the back of her legs. And you can see these red lines, often misconstrued as stretch marks. They are not stretch marks. They are a different level of the dermis than stretch marks. They are caused by neovascularization, which is new blood vessel formation, which is something Bartonella is famous for. Here are some lines on her arms. The most common places we see this is around the thighs and hips, but you really can see it everywhere. Okay, here is her Cunningham panel. I will explain more directly what her Cunningham panel is shortly, but what you can see here is really significant elevation in antibodies. These are all anti-neuronal antibodies, antibodies against her own nervous system. So look at this, 16,000, 640, 8,000. This is an enzyme activation, calcium calmodulin protein kinase 2, which I'm not going to say anymore. We're going to call it CAMK2. And this is an enzyme which I'll be talking about associated with neuropsychiatric problems. Okay, Anna is case number 2. As a child, she had sensory integration disorder, speech disorder, eye tracking issues, constipation, odd hand movements, and facial grimacing and OCD. Okay, so odd hand movements, these are involuntary movements. The medical diagnosis is chorea, that's C-H-O-R-E-A, otherwise referred to as choreiform movements. She had this grimacing, which is really tics, and OCD, this frequently, well, OCD for sure, almost always goes along with PANS, not 100%, but the tics and these involuntary movements are also very common. So that was as a child. Then as a teen, she developed sleep problems, depression, anxiety. She's manic at night. So get this, all day she'd be exhausted, but somewhere between 10 p.m. and midnight, she wakes up, she's up all night, 5 or 6 o'clock, and then she's exhausted the rest of the day. So in addition to that, she had headaches, joint pains with swelling, muscle aches, itching, nausea, heartburn, sugar cravings. Sugar cravings, another sign of food sensitivities, particularly yeast. Recurrent viral infections, pins and needles, numbness, and she'd been labeled as atypical bipolar. Her physical exam was unremarkable except for dermatographia. I don't know how many of you out there are acquainted with that term. It's just a fancy medical description that it's, I think from the Latin, it means skin writing. And basically what it refers to is when there's a mild abrasion of the skin, it turns red, sometimes white, which is, and that's a manifestation of excess histamine release. So you can do this on yourself, you know, take your arm and scratch yourself, see if it leaves a line. Okay, her laboratory turned out she had low thyroid. It also turned out that an endocrinologist had seen her and diagnosed her as having adrenal insufficiency because her AM, her morning cortisol was low. And I said, well, that makes sense, but let's check an 11 p.m. cortisol because that's when you wake up. And then you're manic all night. And sure enough, it was high. She basically had a reversed cortisol pattern. So instead of being high in the morning, low at night, it was reversed. That's why she couldn't sleep all night. Okay, in addition to this, she had a homozygous MTHFR mutation and a low homocysteine. And I'm going to come back and talk about that because those two should not happen in the same person. And she also had mold toxins in her urine. Here is her Cunningham panel, and you can see she had elevations in antitubulin antibody and an elevated CAMK2 activation. Okay, case number 3 is Heidi. She started having tantrums when she was 2-year-old, and again, that's not unusual, but when these tantrums become so severe that she's breaking things and violent, then there is something wrong, obviously. Okay, poor sleep, increasing depression, irritability with rage, anxiety, OCD, cutting, isolating, eating issues, involuntary movements, again, the choreiform movements, chills and sweats. So on exam, when I saw her at 14 years old, many superficial lacerations on her forearms, that was from her cutting, stria on her breasts and thighs, and she had a positive Romberg. And this is something I just want to point out to you folks, because what I'm seeing is pernicious anemia in a lot of patients. So it's a little bit tangential, but here's what a positive Romberg is. It's when you standing up, you put your feet totally together so they're like this, adjacent to each other, and close your eyes. If you tend to go over when that happens, Romberg is present. And that suggests a lack of proprioception in the feet. You're not getting the feedback from the bottoms of your feet. And that's often associated with B12 deficiency. In fact, her B12 was low by my standards. I mean, the cutoff is lower than that. But frankly, if it's less than 400, it's very suspicious. Excuse me, that's assuming you're not a vegan, assuming you're getting B12 in your diet, which we normally get from meat and dairy and eggs. So it turns out her mother had B12. It turns out she has a sister with low B12. They all have pernicious anemia. Okay, in addition to that, she also had 2 mutations at the MTHFR gene, and she also had a low homocysteine. So here's why I'm bringing this up. Oh, not yet. She also had elevated antitubulin antibody and excess activation of CAMK2. Okay, methylation. I don't know how well-versed people here are in methylation. This is what we're looking at is just one little piece of methylation. Methylation takes place in virtually all the cells in the body, and it's well known particularly for detoxification, cellular detoxification, but it's involved with a whole lot of other things. Methylation is involved with metabolism of hormones and neurotransmitters, of generation of methyl donors, and they're involved with DNA repair and modulation of epigenetics and so on. I mean, a lot goes on the basis of methylation cycle. So here's what I want to show you. These patients, the 2 that I just showed you, 2 mutations here at the MTHFR, which converts folate, which is in our B complex, it's in foliage, right? That's how it got its name. So it converts foliage. I lost my arrow. It's in here somewhere. It converts folate to 5-methyl THF, right? That's the active form of folate. And you can see that if there's a mutation in the MTHFR, it's going to slow this down. And if there's 2 mutations, it slows it down 70%. So you can see how slow this cycle would go. And if that's slow, this cycle is going to be slowed. Now, homocysteine should build up in this situation, right? That's what we're used to seeing when we see mutations at MTHFR. But what did we see in these 2 previous cases? We saw low homocysteines. I want to point out, I'm making a big deal about this because I see this in probably 75% of my patients with PANDAS, that they have this combination of MTHFR mutations and low homocysteine. Well, why do they have low homocysteine? The CBS enzyme also I should say the CBS gene can also have mutations. And when the CBS has mutations, it causes upregulation of the pathway. So now what's happening is homocysteine is getting taken down the transsulfuration pathway at a vastly accelerated rate. It's depleting the homocysteine here. And there's a couple things that happen when, and I'm hearing some background talking. I'm not sure what that is. Okay, so so homocysteine is getting metabolized down here for reasons I don't quite understand. That means there's going to be less glutathione, less reduced glutathione, which is what we need. But in addition, homocysteine is not being converted up here to methionine and SAMe, our major methyl donor. So if we were going to measure the intermediaries here, like methionine, homocysteine, SAH, adenosine, cystathionine, and so on, we would see very low levels of methionine, SAMe, and SAH, and so on, and low levels of reduced glutathione. This is really, really important. This is a very, very challenging detox situation, and these people really need support at multiple points in the methylation pathway. Okay, let's move on. We could talk about PANDAS. What is PANDAS? Basically, this is a condition which Susan Sweeto first described. She published in 1994, pediatric autoimmune neuropsychiatric disease associated with streptococcal infections. That's the acronym. And she described kids who were fine, they were healthy, they got a strep throat, and they crashed. They suddenly developed OCD, anxiety disorders, depression, and behavioral problems, and so on. In '96 is when she published 50 cases and actually coined that term PANDAS. And Murphy then did a prospective study and confirmed that PANDAS was indeed associated with these strep infections, group A streptococcal infections. What's this about? Well, it turns out there's immune cross-reactivity between the microbes and the host tissues, which we call molecular mimicry. I want to talk a little bit about rheumatic fever because most people have a sense of what that is. Rheumatic fever is when you get a strep throat and antibodies to the strep then attack the heart valves. Why do they do that? Because there's some structural similarity between the strep bacteria and the heart valves. So in a way, the antibodies get confused and attack our cells. That is an autoimmune problem, but it's also an infection. It's both. It's an infection and an autoimmune problem, and that's what we call molecular mimicry triggering autoimmune inflammation. That's what's happening in these kids, except instead of attacking the heart valves, it's attacking the brain. Okay, children with PANDAS-like conditions exhibit elevated levels of anti-neuronal antibodies against, and this is what's well documented, dopamine receptors, lysoganglioside, tubulin, these are all parts of neurons. So I want to point out that, you know, when for example, you get a strep infection, we can measure antibodies like anti-streptolysin O, ASO, or anti-DNase B. This is one way that doctors will measure an immune response to strep. But there are a lot of other antibodies that are getting generated. And if you are otherwise healthy, but particularly if you have the right genetics and epigenetics, which we'll be talking about, then you will screen those other antibodies and they won't cause a problem. But in people who are otherwise predisposed, those other antibodies attack our cells. In this case, anti-neuronal antibodies attacking the brain. Okay, so here's the whole picture. When anti-neuronal antibodies cross the blood-brain barrier, they activate this enzyme CAMK2. CAMK2 mediates many learning, memory, and developmental cell pathways. It alters dopamine transmission, which is then associated with neuropsychiatric disorders, as well as those creiform or involuntary movements. I'm going to say it once more because this is really the heart of what's going on in PANDAS. Group A strep infections lead to autoimmune encephalopathy. Encephalopathy is just a fancy word, which means there's disease in the brain. Sometimes referred to encephalitis, which means there's inflammation in the brain. We're talking about brain on fire. Group A strep infections trigger antineuronal antibodies. They cross the blood-brain barrier. They activate CAMK2, which in turn increases dopamine. Elevated dopamine leads to neuropsychiatric symptoms and chorea. Okay, moving along. It turns out that strep is not the only microbe that can trigger autoimmune encephalopathy. And a handful of experts got together around 2013, and they put together criteria for the diagnosis of PANS. It's important to have criteria because if studies are being done, we need to know that people being labeled as PANS really fit the same category as some other study where PANS kids are being studied. So criteria are important, and here's the criteria they came up with. The abrupt onset of OCD or severely restricted food intake, anorexia nervosa. No known medical or neurologic disorder that would account for those symptoms, and at least two of the following: anxiety, often panic attacks, by the way, emotional lability or depression, irritability, oppositional behavior, anger issues. I can tell you that these kids can become violent, often oppositional though. Behavioral, developmental regression. Remember, these are kids and they can't do what they used to do. Sudden deterioration in school performance, brain fog, basically. Motor or sensory abnormalities like the tics and choreiform movements that we've talked about. Somatic signs and symptoms, including sleep disturbances, bedwetting, urinary frequency, and so on. Here are the microbes that thus far have been identified as triggering a PANS syndrome. So just so you understand, PANS is simply a broader term than PANDAS. PANS subsumes PANDAS. PANDAS is just one subset of PANS because that's strep. PANS includes any microbe, a syndrome caused by any microbe that triggers this autoimmune encephalopathy. Check out all these viral infections: herpes simplex, influenza A, varicella zoster. That's shingles, by the way, and it's also chickenpox. Epstein-Barr, HIV, and common cold. These are all, by the way, common cold is often a coronavirus. A lot of viruses can trigger this. Recurrent sinusitis, mold, Bartonella, and Mycoplasma. I'm going to talk more about those because they are two very common tick-borne co-infections. And no surprise, SARS-CoV-2 has been reported as triggering PANS syndrome. Okay, what is the Cunningham Panel? Well, we can thank Madeline Cunningham. She's another great researcher who basically described what's happening in these patients. They have elevated levels of different antineuronal antibodies, and here they are: anti-dopamine receptor D1R, anti-dopamine D2L receptor, anti-lysoganglioside GM1, anti-tubulin, and the activity of this CAMK2 enzyme. Okay, in a very elegant study, this was done by Craig Shimasaki at Molecular Labs, and Craig had a whole lot of clinicians submitting data to him. They screened 206 patients who fit the criteria for PANDAS or PANS and tested them before and after treatment for the Cunningham Panel. Out of that 206, 58 met the strict criteria. And out of those 58, 34 improved, or they actually symptoms totally resolved, and 24 did not improve, or some worsened. Well, what was important is among the people who improved, their Cunningham panels got much better. And among the people who did not improve or worsened, they didn't get better, or in fact, they got worse. So they claim that the correlation of the Cunningham panel with neuropsychiatric symptoms had a very high sensitivity, 88%, and a specificity of 83%. The obvious question here is, How often do normal people have a positive Cunningham panel? And I can tell you it's less than 15%. This is something that's been looked at independently. Okay, let's talk about Lyme disease and co-infections and psychiatric disorders. So here it is, psychiatric conditions related to Lyme disease complex. You know, I've already shared with you in the beginning that it's often, excuse me, it's often psychiatrists and other mental health workers who suggest to patients that they might have an organic illness underlying their mood issues. And I can tell you that these mood issues can be severe, really severe. Anxiety, agitation, panic attacks, depression, irritability, anger, oppositional rage, OCD, phobias, schizoaffective disorder, bipolar disorder, eating disorders, alcohol or drug abuse and other addictions, anhedonia, a fancy word for just lack of joy, dissociative episodes, quite common actually, personality disorders, even schizophrenia and suicide. Sadly, suicide is the most common cause of death in people with Lyme disease. I want to talk about the association of Lyme disease with PANDAS, and I'm going to start off by saying there are no documented cases of this. What we have is a lot of, what can I say? We have a lot of data that suggests there's an association, but we don't have a slam dunk case. Basically, the neuropsychiatric symptoms of neuroborreliosis, which is a fancy way of saying Lyme disease that affects the nervous system, they parallel that of PANDAS. You've seen that. Antineuronal antibodies, remember that's what we're talking about here, they're actually present in 50% of people with the so-called PTLDS syndrome. I hate the term PTLDS, it stands for post-treatment Lyme disease syndrome. Doctors now finally admit that 10 to 20% of people who are treated for acute Lyme go on to have chronic symptoms. And this is the label that suggests that they don't have Lyme anymore. They have some sort of PTLDS syndrome of unknown cause. Well, we know what causes it. They do still have Lyme, but even more importantly, they all have co-infections. And in that group, 50% have antineuronal antibodies. Well, one of those antibodies is an antibody to outer surface protein A, which shows up as band 31 on the Western blot. And that particular protein has a sequence similar to strep. So already you can say, whoa, this is really suggestive. And also that outer surface protein is associated with autoimmune reactivity. So the plot thickens, right? People with a prior history of Lyme disease often have positive Cunningham panels. So can we say Lyme disease is a trigger of PANDAS? I actually don't think we can. We don't have a documented case, and I don't think we will have a documented case, and that's because we never see Lyme without co-infections causing these problems. So how can we indict just the Borrelia burgdorferi, the Lyme pathogen, when these other pathogens are present as well? So speaking of co-infections, here's 7 that we see, and I've highlighted the top 3, Babesia, Bartonella, and Mycoplasma, because these frequently cause neuropsych symptoms. Bartonella and Mycoplasma, I'll talk about more detail, have been documented as causing PANDAS. Babesia probably does. I've certainly seen cases that make it look likely, but it has not been documented in the literature. Okay, so this is Rosalie Greenberg. Rosalie Greenberg is a child and adolescent psychiatrist in New Jersey. She's Lyme literate, she's great. And she described 27 youth who were referred to her with pediatric bipolar disorder. Now, I know there's controversy, does that even exist? But clearly they had mental health issues that were pretty severe. And the mean age was 7 years old. 15 were diagnosed as bipolar 1 and 12 bipolar 2. This has to do with whether they had manifestations of manic behavior or not. Doesn't matter, they had severe mental health issues. And she ran tick-borne profiles on them. And she found that 89%, 24 out of 27, had antibodies to tick-borne pathogens. So check it out, Babesia in 16, Mycoplasma pneumonia in 11, Bartonella in 8, and Lyme in 6. Okay, I just want to give special attention to Bartonella because it's a bad one. I mean, the worst neuropsych symptoms we see are from Bartonella infections. When someone comes in with, just severe anxiety, panic attacks, suicidal depression with rage and so on, first thing we wonder is, do they have Bartonella? So here it is. Bartonella has been, this is all in the literature, right? Medical literature: anxiety, panic attacks, depression, OCD, anger, rage, oppositional defiance disorder, phobias, substance abuse, psychosis, personality disorders, bipolar, schizophrenia, schizoaffective disorder, and PANDAS. All of these have been well documented in the literature. This was an amazing report by Ed Breitschwert. He's in North Carolina. He's a world expert in Bartonella. Published a whole lot on Bartonella. This is fairly recent, December of 2020. He described 33 patients with the recent onset of neuropsychiatric symptoms, most of which were irritability, rage, anxiety, panic attacks, and depression. Obviously, a lot of people had all those, and a handful of other symptoms, including somatic symptoms. Okay, out of those 33, 29 had serological or PCR evidence of Bartonella. Serological means antibodies. PCR means they found the DNA of Bartonella in these patients. That is a very high number. Now, it is absolutely true that if you test a quote unquote control or healthy population, you will find 10 or 15% who are positive for Bartonella, even by PCR. But you're not going to find 29 out of 33. And out of those 29, 24 had concurrent cutaneous lesions. Okay, they had skin lesions. And when they biopsy, this was a different report, but they've biopsied the stria that I've been talking about, and they find Bartonella there. And here's another picture of Bartonella stria. You can see this looks like this person's been whipped. And they've been told, guess what they've been told? That these are stretch marks, really. Okay. Mycoplasma. Mycoplasma, there's several species of Mycoplasma. Mycoplasma pneumonia is the most common one. This is well known as a respiratory pathogen. It can cause anything from cold, sore throats, ear infections, to bronchitis and pneumonia. And in fact, is a very common cause of bronchitis and pneumonia. But guess what? It can cause systemic inflammation, and it can cause neuroinflammation. It can cause significant encephalitis. So in terms of neuropsych symptoms, it's been demonstrated to cause acute psychosis, OCD, mania, eating disorders, and PANDAS, right? I would say easily over half my patients with PANDAS have Mycoplasma. Way over half my patients with PANDAS have Bartonella. I want to tell you about a pilot study. This was a study that I did here in Colorado with Nancy Brown, a physician here in Colorado. And basically, there is an adolescent residential treatment center up in Estes Park. And kids there are all diagnosed with major depressive disorder. This is DSM-5 diagnosis. And other mental health problems, particularly generalized anxiety disorder. They basically were too sick to make it at home. They couldn't live at home. They couldn't go to public school. But this residential treatment center was basically housing them and caring for them. And the center has a very good reputation. These kids do not have any known organic problem, no known physical illness, with the exception of one who was diagnosed with celiac disease. Well, we took 10 at random and tested them for antibodies to Lyme, Bartonella, tick-borne relapsing fever, anti-DNase, which is antibodies to strep, and the Cunningham Panel, you might say, you might ask, why did we test to those 3 microbes in particular? Is because that's what IGeneX was willing to do for free. Okay, and here's what it showed in terms of antibodies to these microbes. Lyme, Borrelia burgdorferi, half of them, 5 out of 10. Bartonella, 3 out of 10. Tick-borne relapsing fever, 4 out of 10. I just want to remind you, tick-borne relapsing fever causes Lyme syndrome, not just relapsing fever. And then some of them had more than one bug. But these were positive enough that it would be well accepted positive, and I was able to get it published. But if we were interpreting it the way a Lyme literate doctor would interpret the Western blot and so on, then I've labeled this probable. And what it comes down to when we look at the probable diagnoses, the total was 9 out of 10 probably had exposure to tick-borne infections. So here's what we found. Out of these 10 adolescents with severe depression, while 6 out of 10 clearly had antibodies to the tick-borne pathogens, probably 9 out of 10 had exposure. 3 out of 10 had elevated strep antibodies, and another 1 out of the 10 had borderline strep antibodies. But get this blew us away. 9 out of 10 had elevated antinumeral antibodies consistent with autoimmune encephalitis, that is PANDAS. 9 out of 10 of these kids who were diagnosed with a primary mental health disorder. And I want to thank Molecular Labs, who donated their services to do this study. So let's talk about treatment, okay? PANDAS treatment. Here are the major treatment modalities: antibiotics, anti-inflammatory agents, intravenous gamma globulin, psychotropic medication, psychotherapy, and other immunomodulatory therapy. So let's get into more specifics. Understand that there are no controlled studies, nor will there ever be controlled studies, because we're not going to take kids like this and give them placebos. What we have is uncontrolled surveys, and in this was the biggest one that's been done. 600, almost 700 patients diagnosed by physicians with PANDAS. Almost all of them had antibiotic treatment, and you can see what else they got: anti-inflammatories, intravenous gamma globulin, psychotropics, and psychotherapy. Okay, the most effective of all the interventions was aggressive broad spectrum antibiotics. And I wrote duration greater than 30 days, that's all they would say, but generally we're talking about months and months of antibiotics. The ones that are most studied were beta-lactam, that's basically penicillin, beta-lactam antibiotics, and azithromycin or zithromax. These were the best studied. It doesn't mean they're the best antibiotics out there, it's just the ones most commonly used. Anti-inflammatories, somewhat effective in relieving symptoms, and these include non-steroidal anti-inflammatory agents like ibuprofen, steroid tapers, which I don't recommend in these kids with chronic infections, and antihistamines, which I'll come back and talk about that. IVIG, basically we're talking about giving kids antibodies. These are antibodies that are collected from a whole lot of different people and concentrated in intravenous, that's administered over several hours, usually about every 3 weeks. Now, it's very interesting. These antibodies do 2 things in particular. One is they stimulate the immune system, but the other, paradoxically, is they have anti-inflammatory action. IVIG is recommended for different autoimmune illnesses and neuropathies and so on. So IVIG was effective in many patients, particularly if they had a low IgG, that is a low gamma globulin level to begin with. That's a condition called hypogammaglobulinemia, and it suggests that their bodies simply are not going to fight infections well. Unfortunately, the IVIG administration, when it's effective, after it's withdrawn, it's not always sustained. Here's the problem with IVIG. It's expensive. I mean, it can cost easily $10,000 to $13,000 a dose given every 3 weeks. If you're not Bill Gates, you're a mere mortal like the rest of us, basically it's not available unless your insurance is going to cover it. And that's the trick. It's a challenge, but often, sometimes we can get insurance to cover it. Insurance companies will not routinely cover it for PANS. They have other criteria, and sometimes we can get people in on other criteria, such as a low IgG level. There is an exception to this, and that's the state of Illinois. Illinois has mandated that IVIG be covered, basically any treatment prescribed by a doctor for PANS be covered. And I'm wondering, I suspect that there are families moving to Illinois simply to get this treatment, just like families moved to Colorado to get CBD treatment for their kids with seizure disorders. Okay. Psychotropic medications, SSRIs more effective than other psychotropic treatment, but often not that effective. Quite frankly, psychotherapy, excuse me, I think the most important thing about psychotherapy is simply support, because the kids got to know you're not crazy. You got brain on fire, and we're going to do everything we can to support you and help you get through this, because you will get through it. Plasmapheresis, this is a pretty aggressive technique where basically your entire blood volume is filtered. The antibodies are filtered out. And most of the kids who went through this did have initial improvement, but most of those found that the improvement was not sustained, and it's not something you can keep on doing. Rituximab is a monoclonal antibody. It's also gotten some attention with COVID. We really don't have data. There are just a few cases that I'm aware of, not reported, but just among my colleagues who've seen some benefit with that. Ami Katz is a neurologist in Southern Connecticut, Yale trained, very interesting physician and friend of mine. And I think it was 2016, maybe, 112 patients he presented that were diagnosed with PANS. And all of them had Lyme disease. They all had IgM positivity to outer surface protein A. Again, that's PAN31. They all had symptoms consistent with PAN. They had these involuntary movements, the choreiform movements on exam. They had HLA-DR4 positivity. Okay, so HLA typing is something we do, for example, with transplant patients to check out whether genetics are compatible. And this particular allele, it's associated with autoimmune disorders. They had, remember, Dr. Katz is a neurologist, and he studies them. They had evidence of damage to peripheral and central nervous system, brain MRI, EMG, and nerve conduction velocity studies. What he found was that the antibiotic most effective in this setting was, excuse me, long-acting bicillin. For those of you who are old as I am, I know not too many of you out there, but when we got strep throats as a kid, we got a shot of penicillin. It was a big shot in the bum, and it was long acting. It was good for 2 weeks. That's all we needed. One shot of penicillin. That did you? Well, Ami Katz found that LA bicillin worked quite well, best by itself. That is not with other antibiotics. I've given you doses there, 600,000 a week injection if less than 100 pounds, and 1.2 million if greater than 100 pounds. And he found that it was more effective than IV antibiotics or corticosteroids. And his protocol was, if that's not effective, then put them on IVIG. It's not specifically what I would recommend. I do think that everyone with PANS who's not doing well deserves a trial on LA bacillin injections for at least 10 weeks. I have had quite a few patients get significant relief from this, but we don't know how it works. There's nothing in the medical literature to suggest it is immunomodulatory, and it's not a great drug to treat Bartonella. It'll hit it somewhere. It'll hit it extracellular, but it's not intracellular, and it's not going to hit Mycoplasma. So there are other drugs that can be, other antibiotics that can be used besides LA bacillin. What about mast cells? Well, we're finding that there's mast cell activation is common in a lot of autoimmune disorders. And here I've listed a bunch which have been associated with mast cell activation disorder. So for those of you who don't know, excuse me, those of you who don't know, mast cells are white cells. They're sort of primitive white cells that are really designed for protection. They inhabit mucous membranes near orifices, but they contain about almost 200 inflammatory mediators, including histamine. And when they get triggered, they release these mediators. Now, mast cell release of these mediators that's called degranulation, does result in what we recognize as allergy problems like just hay fever or hives or even anaphylaxis. That's all caused by mast cell activation. But it can cause inflammation all over. And it is associated with a lot of different symptoms. And it turns out with these infections, we often have excess mast cell activation, so that the threshold that the mast cells need before it triggers the release of all these inflammatory mediators gets lowered. So it's sort of like they're trigger happy. And here are the things we do for mast cell activation syndrome. Antihistamines, H1 blockers are your regular antihistamines. H2 blockers are things like Pepcid and Tagamet, which are actually anti-acid medications. Diamine oxidase is an enzyme that actually degrades histamine. Leukotriene inhibitors. Leukotrienes are dramatically more inflammatory than histamine. Singulair, which we use routinely for asthma, can inhibit leukotriene. Diet, it may be important for people to go on low histamine diets and get off foods that trigger mast cell activation. You can Google this one. And then there are agents that actually help to stabilize the mast cells so they're not as prone to degranulate and release their inflammatory contents. Quercetin is over the counter. It's a bioflavonoid. It's normally found in the rinds of oranges and grapefruit, that white stuff that typically we pick out and don't eat. Ketotifen, this is available in compounding pharmacies. Cromolyn, also known as gastrochrome, by prescription, all clear. This is something new to me. It's actually derived from quail eggs and also can help stabilize mast cells. Okay, what else do we do? Okay, in terms of antibiotics, I've mentioned LA bacillin, I've mentioned azithromycin, but we should be thinking about anti-Bartonella drugs as well as anti-Babesia drugs. I just want to mention, we need to be really careful with antibiotics here. And we have to go slow and careful because we can trigger really bad Herxheimer reactions. I think most of you know what a Herxheimer reaction, basically it's a flare in symptoms associated with killing the microbes. It seems to be associated with a cytokine cascade. And particularly when we hit Bartonella, we can see really terrible Herxheimer reactions. When I start to use antibiotics in this patient population, we do it one little step at a time, always separating out interventions and always starting slowly. Anti-inflammatory agents, we've talked about NSAIDs. CBD is anti-inflammatory, essential fatty acids, boswellia, curcumin, PEA, which seems to be helping a lot of people. So all of these things can help. Again, I never start more than one thing at a time. IVIG, for if people are not responding adequately to antibiotics, and we can get it approved. Treatment of mast cell activation syndrome, but there's more that we can do too. Most of my patients have some food sensitivities. Remember that once they've developed this inflammatory syndrome, they develop a hypersensitivity syndrome, and they become sensitive to foods that they weren't sensitive to before. I would say that dairy, yeast, sugar, eggs, and corn would be the most common ones I see, but certainly, especially those with significant mast cell activation syndrome can be sensitive to a lot of others. Excuse me. Mold issues. Okay, I can't tell you what a big problem mold is. Again, the mold might not have been a problem before they got this autoimmune condition, but now they become sensitized. They're in a hyperinflammatory state, and now they're reacting to mold. And it can be a big problem. People say, well, you know, you live in Colorado, it's really dry there, you don't have mold problems. Not true. Anyone who's tried to buy a house and has done mold surveys found out it's really hard to find houses without mold. Enough said. Low dose immunotherapy is basically treating these microbes as if they were allergens and giving neutralizing doses of immunotherapy. And there is one person I've found on the internet who claims she's getting good responses doing this. I don't have experience. Low dose of naltrexone. So also, I'm not going to spend time on this. Suffice it to say that this also has anti-inflammatory action. I have not been that impressed by its efficacy. Remember that these people have these multi-sensitivity syndromes. They might have developed multiple chemical sensitivity syndrome. They might have developed electromagnetic field sensitivity issues. You know, we could talk a whole other hour on just those. Okay, stress intervention. Oh my God, these kids and their families need a lot of support. We know that this is causing a lot of stress in their bodies, and the stress itself can actually augment the autoimmune disease. You know, this is weird because it's taken a long time for Western docs to acknowledge and accept and embrace the concept that stress, that, you know, whatever's happening outside us that we experience as distress can affect our bodies in causing psychosomatic illnesses, right? But it's so interesting how many doctors don't grasp that organic disorders can cause mental health issues. They've taken it one direction, they can't go the other direction, and it's not as if they're separate at all. And it's weird. I'm sure this is true for some of the people who are listening to this right now, that they've gone to pediatricians who said, oh, I don't believe in PANDAS. Well, PANDAS is not a faith-based issue. It's a science issue. and it's quite real. And it's sad that it's not better recognized. So occasionally SSRIs are effective. Counseling, cognitive behavioral therapy, particularly support understanding. Biofeedback I have seen help some people. Okay, we're wrapping it up, folks. Conclusions. So, chronic manifestations of infection with Borrelia burgdorferi, that's the Lyme pathogen, both post-treatment, that's the so-called PTLDS syndrome, where people have been treated for acute Lyme, but then continue to be symptomatic, and previously undiagnosed. Most of my patients who come to me with chronic Lyme wasn't diagnosed for years, are associated with persistent infection and immune abnormalities. Patients with chronic Lyme disease complex have persistent infection with co-infections as well as Lyme. I do not see people with just Lyme disease. And that used to be in my chronic Lyme population. But now, even in my acute Lyme population, people have come to me within a month, 2 months, 3 months of having a tick attachment and developing Lyme disease. They all have co-infections too. Patients with persistent tick-borne infection often manifest hyperreactivity, autoimmunity, and immune suppression. Lyme and its co-infections often present with serious neuropsychiatric symptoms. And again, remember, once you present with neuropsychiatric symptoms, you're going to be relegated to the mental health world, and no one's going to be paying attention to organic issues. Multiple microbes are capable of stimulating cross-reactive antineuronal antibodies that result in autoimmune encephalopathy, that is, PANDAS. Many patients with microbial-induced autoimmune encephalopathy do not meet the full diagnostic criteria for PANDAS. This is important. It's like you don't have to have the acute onset of a symptom like strep throat. A week later, boom, OCD. You don't have to have an acute onset. Only if you're going to be in a study population do you have to meet that criteria. Also, it's not limited to the pediatric population. This occurs in adults too. And I've actually wrote an article, and it's in the medical literature, where I suggested we change the name. Instead of PANDAS, it should be MANS, Microbe-Induced Autoimmune Neuropsychiatric Syndrome. The Cunningham Panel, thank you, Madeline Cunningham, is a good marker for the presence of autoimmune encephalopathy. I want to point out that Bartonella and Mycoplasma species can trigger autoimmune encephalopathy, and they cause big time. I mean, most of my patients have one or both of these, and as yet there's no documentation that Borrelia burgdorferi, the Lyme pathogen alone, can do this. And finally, looking back to that pilot study, I think we have to conclude that a significant subset of adolescents experiencing anxiety and depression, and this is going up. I mean, this has become its own epidemic, right? Have organic illness with evidence of tick-borne infections and autoimmune encephalopathy. 9 out of 10 of those kids chosen at random had positive Cunningham panels. The question is, does the same apply to adults? How many adults out there who have anxiety and depression syndromes or bipolar, how many of them actually have autoimmune encephalopathy? So my question to this audience is this an epidemic? And is it related perhaps to other epidemics in the 21st century? Well, what are those other epidemics? I mean, check it out. Not just Lyme disease, autoimmune illnesses in general, chronic fatigue syndrome, fibromyalgia, most of which I think are in fact Lyme disease, not all. Autism, food sensitivities, asthma, cardiovascular disease. This is mainly an inflammatory disorder. Adult onset diabetes, obesity, mood and behavioral disorders, ADHD. I mean, there's a lot of epidemics going on in the 21st century. Like, what's up with that? So what's the origin of an epidemic? Constellation of environmental factors, communicability, and susceptibility. I mean, we think about this now, particularly in relation to SARS-CoV-2, but I'm thinking about more long-term issues. So particularly, I want to look at this susceptibility issue. There's genetic susceptibility and epigenetic, and I'm going to tell you what epigenetics refers to. While our genes generally don't change much, except over millennia with so-called natural selection and survival of the fittest, I don't know how much that's actually happening anymore, but that's basic genes are fairly stable. But there are proteins that sit in our genes, and they turn the genes on and off. And these proteins can change from one generation to the next, depending on what's happened to the parents, both the mother and the father. Okay, I'm going to come back to epigenetics. Developmental factors. I mean, what makes someone predisposed besides genetics and epigenetics? Well, what about general nutrition? What about exposure to toxins? What about stress and trauma? Okay, so what's happened in the past 100 years? Well, changes in diet. We've seen nutrient depletion, excessive sugar intake. I mean, really excessive. Food additives, GMO foods. I mean, if you compared our diet to the one 100 years ago, big, big difference. Exposure to xenobiotics. These are foreign substances, hundreds of thousands of which humankind is not exposed to 100 years ago. Herbicides, pesticides, formaldehyde, VOCs, et cetera. I mean, the list is endless. Household, think of it, fabric softeners, air fresheners, scented candles. You know, you go into my cul-de-sac and you smell fabric softener coming from dryer vents, and that stuff is toxic. EMF exposure, wow. This is slowly getting acknowledged as a problem. and will become more and more of a problem for obvious reasons. And I think another generation is going to be recognized as such. But there's other things that have changed. Think about the breakdown of community and social support. So 100 years ago, we used to live in communities and extended families. That broke down to nuclear families, and that, guess what? Now we have a lot of single parent families. Now we have absent parents, we have homelessness. I mean, there's been a general breakdown in support structures. We know that isolation leads to depression, and get this, anxiety issues and PTSD, they can be passed on to offspring through epigenetics. That's right, you can inherit PTSD. All these environmental factors, everyone that I've mentioned, the diet changes, the exposure to all those xenobiotic agents, the stress factors in parents, all these factors result in epigenetic changes that are then bequeathed to our progeny and are cumulative from generation to generation. This is a snowball. With each generation, this is getting worse. And babies are no longer born with a clean slate, if we ever were. So my question then is the autoimmune response to microbes, what we're seeing in this PANDAS population, a reflection of our increasing susceptibility to immune dysregulation because of these compounding factors? Is autoimmune encephalopathy result, I'm repeating myself, of the cumulative stresses and epigenetic changes brought about by the multiple changes in the physical and social environment in the past 100 years? Is autoimmune encephalopathy just one manifestation of widespread chaos in our regulatory systems? You know, that's not just our immune system, but our nervous and our endocrine systems, which of course are not separate systems at all. A major issue in the rising incidence of anxiety, depression, other mood and behavioral disorders is autoimmune encephalopathy causing a whole lot of the problems we're seeing with mental health issues, and is it reaching epidemic proportions? Okay, so this is a real down note. I understand that, and I'm sorry to sort of end on that, but I want to point out that in terms of treating, recognizing, and then treating our children, adolescents, and adults really with PANDAS, they do respond to treatment, and most of them get much better. Some of them turn around quickly, and some of them it takes quite a while, but they do get better over time. There is very much hope, and that leads me to my last slide. Hanukkah is about hope. It's about light in the darkness, and me and my family, we join in wishing all of you a happy holiday season. You should all be well. Thanks very much.
Thank you so much, Dr. Kindler, for this amazing presentation. We do have some questions, so just bear with me as I scroll to the top. And Monica and I will take turns asking the questions. So the very first one, this actually, two individuals asked this out of the gate. You had mentioned earlier in your presentation about an individual in North Carolina. Can you mention who that person is? Who did you, this was at the very beginning of your presentation, and there was an individual in North Carolina you were referencing, and two individuals are curious of who that is.
Well, the only individual I recall mentioning, and it wasn't that early in the presentation, was Ed Breitschwert, who is an expert in Bartonella. He's published a huge amount on Bartonella. And by the way, he's a veterinarian. And Bartonella in veterinarians is a huge, huge problem. You know, their mental health and suicide rate are quite high. And I suspect that has an awful lot to do with cat scratches, right? That's the only North Carolina person I can remember referencing.
Thank you.
Okay, someone I can see. It's Breitschwert. That's B as in boy, REITSCHWERDT. And you know, you can see him referenced in, you know, the list of references from the PowerPoint should have been distributed. If it's not, it will be distributed. And you'll see him on that reference list.
Okay, so Jody, can you turn on my video, please?
Oh, sure, absolutely.
Thank you.
There you go. Oops. I think I grabbed the wrong person here. Give me one moment. Sorry.
You got me too, though. That's
Okay.
good.
Yeah.
Yeah.
There. Okay.
So let's see here. Okay, so the next question we have is from Luke. And I did want to say before I get to the question, we do have those references in a link on the COTBDAA website, and that is under the event for Dr. Kindler today. So you can find those references posted there. I believe they're also posted on Meetup. Is that correct, Jody?
Yeah, they are getting posted on Meetup, and they'll also be posted on our Facebook page as well.
Sounds good. Okay. So the next question is from Luke, and I think this question got answered after he asked it, but I'm just going to put it out there anyway in case he did not catch that or others did not catch that. What are the alternative antibiotics if allergic to penicillin, and also can adults get PANDAS?
Okay, well, adults can definitely get PANDAS. We have to call it something else because PANDAS starts with a P, which is for pediatric, but they get the syndrome we recognize as PANDAS. And, you know, we choose our antibiotics based on what microbes we think we're treating. With Bartonella, the most common medications that we use are a sulfa drug called Bactrim or Septra. The generic is sulfamethoxazole trimethoprim. We also use rifampin. We sometimes, but not that often, use fluoroquinolones, which include Cipro and Levaquin. Those are challenging drugs, and we don't use them very frequently, even though they're very effective. And then there are a lot of botanicals that we use as well.
Okay, thank you. Jody, do you want me to do the next question, or do you have this one?
No, I've got it. Thank you.
Okay.
This one's from Debbie. What is the prevalence of Lyme disease in the ASD community?
You know, that's a fantastic question. Debbie, I think wouldn't that be an amazing study? I do know that there are doctors who specialize in autism who are diagnosing Lyme disease. I know that Kenny Bach, who's in, and his brother as well, actually, Steve Bach, they're in Rhinebeck, New York. I know that also, I think Robert Bransfield has written about Lyme disease and autism. I know there are doctors out there who are looking at Lyme disease in autism spectrum disorders, but I can't give you any numbers. It's not something I personally deal with.
Okay. And Debbie had a follow-up to that as well, which is there research on this? And it sounds like you listed a couple of, at least a few people that are doing research on this issue.
Yeah, and in fact, Kenny Bach had a book come out just this past year. Brain Inflamed, I think is the name of it.
It is. It's a fantastic book. Yep.
Yeah, so that would be a good reference.
Go ahead, Monica. I had to close the blind,
okay.
so I wasn't
No problem.
everybody.
Yeah. Let's see. The next question we have from Debbie as well. Many kids who have been diagnosed with PANDAS, but doctors don't treat Lyme and symptoms aren't improving. How much do you think strep, HHV6, flu, Coxsackie, etc., cause symptoms versus Bartonella, Babesia, and Borrelia in children with chronic cases? And how big of an issue is this in getting treatment?
I think
That's
a great question, and
yeah.
I think they're total unknowns. In a way, I see a selected population. You know, someone's not going to really get into me unless they make a good case that they have tick-borne infections. Now, a lot of them do have reactivation of different viral infections, with Epstein-Barr being the most common. But we often, you often see elevated high antibodies to Coxsackie and so on. While we do have medications that treat the herpes family, which includes not just herpes simplex, which is oral and genital herpes, but it includes Epstein-Barr, it includes cytomegalovirus, it includes human herpes virus 6. We do have medications that can treat them. We don't really have good medications to treat these other medications, these other viruses rather, that were cited, like Coxsackie. So, you know, I think what we look for is, you know, what are the things that we can treat, and hope it makes a difference.
Hey, Monica, since I have a hard time with big words, you want to take the next one?
Sure, let me find that one, because I was reading off a page. Let's see.
You see it for the autoimmune, and I'll go ahead and just take it, and then you guys can.
I can help you with the word. I
Thank
can't.
you.
Yeah.
I am not sure who this individual is because of their abbreviation on their name, but they're saying, I thought autoimmune and
Encephalopathy. Yes.
thank you, is another word for autism. That's a question.
Okay, no, it's not. Encephalopathy is a very broad term, and all it means is disease of the brain. But autoimmune says the disease is mediated via some autoimmune mechanism, okay? As opposed to, for example, you could have a viral encephalitis where there's a virus that's attacking the brain, or you can have meningitis, for example, also. But this is an autoimmune mediated disease of the brain. And it is, I have not seen that term used in relationship to autism spectrum disorders, but it's conceivable.
Okay. So to answer the question is, where's our Facebook page, or where can we find those references? So the Facebook page, it's a private page. And so if you go to Colorado Tick-Borne Disease Awareness Association and link to the Colorado Lyme and Tick-Borne Disease Support Group, you can ask for an invitation to that private patient page as well. And if you need to, I can send you a link, or Jody can send you a link to that as well. The next question on the talk is, how long do you typically keep your patients on antibiotics once you find a combination that works?
Another great question. You know, I'll have to start off by saying there's no such thing as typical with these patients. They're all different. You know, people often, I used to be asked routinely, well, how do you treat Lyme disease? And I finally came up with a response, which is I don't. I treat people, they're all different. And so there's no recipe, there's no cookbook. And, but, you know, the question was asked in such a way, you know, okay, this person's on antibiotics and they seem to be in remission. So how long do we keep them on these antibiotics? I'm gonna approximate that once they're in remission, I would keep them on antibiotics for a few more months, but probably during that time, if they're not already, I would be transitioning them onto botanical antimicrobials, and I would leave them on the botanical antimicrobials probably for a year.
Great. This question is from Lisa. So curious, this is from Lisa. I had a significant asthma as a child. I had significant asthma as a child and thus repeated lung infections. I'm pretty sure I had strep at least once and other ones requiring lots of both antibiotics and prednisone. I started having pretty significant insomnia at a very young age, and by preschool seemed to have developed what appeared to be both anxiety and subclinical OCD. I'm sorry, I just lost it there. I did go through a period of excess hand washing as well. By 12, I'm so sorry, I'm having a hard time with this scrolling with these messages coming up. There we go. Insomnia with OCD. I did go through, I'm having a hard time scrolling today. There we go. go through a period of excess hand washing as well. By 12, I was seriously depressed and had full-blown anxiety, then severe depression and anorexia nervosa for years, and now long-term severe depression. GAD, possibly PTSD and other. What are the possibility that I had this as a child? How would I find out? And what can I do about it now if that was the case?
Wow. Lisa, I'm really sorry to hear what you've been through. I would say you probably did have this as a child. You know, if I was taking your history, I ought to be asking a whole lot of questions. I would also point out that with all the antibiotics and steroids you were on, you probably have developed yeast overgrowth and yeast sensitivity, which would manifest as making all of the symptoms we were talking about worse, and would particularly cause predominant sugar cravings and stuff like that. I don't know if it matters, you know, when this happened. All I can say is probably started when you were a child and then got worse over time.
Okay, thank you, Dr. Candelaria. Next question, I believe is from Dr. Birkmeyer. If infections can trigger autoimmune encephalopathy in susceptible individuals, have you seen vaccines trigger this as well?
Wow, this gets into controversial areas, doesn't it? In my patient population, I have definitely seen, for example, the COVID vaccine trigger these symptoms in people who previously had those symptoms, and then the vaccine seemed to trigger a relapse. I don't have experience treating people who never had Lyme and co-infections with, who then developed COVID or some other virus. And so I just don't have that clinical experience to say, well, could the vaccine trigger that? And I do know that the vaccines have triggered a whole array of problems, but the ones that I see are people who already have Lyme and other tick-borne infections. And the vaccine particularly triggers Bartonella and Mycoplasma problems, but it can trigger a full-blown relapse.
Do people with Lyme typically have Epstein-Barr as well?
Okay, so Epstein-Barr virus, which is the virus that causes mononucleosis, is a very common virus. It is in the herpes family. And most of us have been exposed to Epstein-Barr. If you tested everyone on the block, almost everybody would have some antibodies to it. And what happens with Lyme disease is because there's immune suppression, that otherwise dormant microbes can become reactivated. And we definitely see that with Epstein-Barr in terms of how frequently we see it. I think I'm thinking of my patient population, and it's probably less, it's definitely less than 50% where we see a really significant elevation in antibodies consistent with reactivation.
Okay, thank you, Dr. Candelaria. Another question from Luke, who also thanks you. Luke is wondering who he can see in Denver that practices like you, since you're not taking patients. I know, similar to a lot of patients, people are struggling to find a doctor that understands the whole picture.
Yeah, I am taking new patients, but it's incredibly slow. I have a long waiting list and I don't have very many spots opening. So I'm sorry that I can't be more accessible. There are doctors that I do refer to. Jordan Brown is here in Denver, Nancy Brown in Louisville. I refer to Dr. Julie Barter, who's actually in Montana, but she comes down to Colorado every 3 months or so. I know she has supper with us when she does, who's very good. Those are the docs that I feel most comfortable referring to. And I think all of us have a backload of patients, unfortunately.
Thank you. Yes, it is a widespread issue with access to doctors that understand. So, do you have the next one there, Jody?
I do. This is from Rachel. What's your thought on psoriasis and TBDs? I have a daughter who developed later in her teen years and currently in young adulthood.
I'm sorry, was it psoriasis?
Correct. And TBDs.
That's an interesting one. I'm trying to think of my clinical experience with this. And I know I've seen it, but it hasn't been recently. And it often does respond when you treat the infections. Psoriasis is considered an autoimmune disorder. I'm going to go a little tangential here. The most common drugs now being prescribed for quote unquote autoimmune disorders are the biologicals. You see them advertised on TV all the time, like Humatin for Crohn's disease, as well as psoriasis and so on. These drugs suppress the immune system. And my patients who've been put on these drugs consistently flare, get much worse. So you have to be really careful with those drugs. And by the way, those drugs right now, they're the biggest moneymaker for pharmaceutical companies. They love to make drugs that you're going to take the rest of your life. And botanicals fit that picture, not biologicals, not botanicals.
Thank you. Next question is from Debbie. What would have to happen in the industry for insurance to cover doctors and treatments? Makes me sad that so many people can't afford to see doctors.
Well, that's a social question, isn't it? Social economic question. Here's the thing. Western medicine, I think, has done a really good job at treating acute illness. It's done a really lousy job at treating chronic illness. And it's just not appreciated that people who are chronically ill have a whole lot of different imbalances and need in-depth detective work, which takes time and attention. When patients first come to me, the first appointment averages 2.5 to 3 hours. And, I'm trying to get as big and in-depth a picture as I can of what's going on in this person and trying to connect dots and understand what the patterns and then make conclusions about where do we go from here and what tests should we do and so on. Well, I would be covered if I choose to align myself with an insurance company, but they wouldn't pay me to spend 3 hours of time. They would spend me to pay half an hour of time. That's, doctors I know who are working in a hospital-based setting or just a group practice, they get 15 minutes for a patient. I mean, even my follow-ups are usually an hour. So, what can I say? We have to have a whole different attitude, and I don't know what to do about it. I just don't know what to do about it.
Does dynamic neural retraining system and Hopper help with PANDAS?
That's a great question. I've started recommending it. I don't have the feedback yet to know. It is something that has helped a lot of people who have hyperreactivity, hypersensitivity, and particularly in association with PTSD. And it is something that I think we should be looking at in terms of how else to modulate the inflammatory response in the body, the hypersensitivity, hyperreactive, hyperinflammatory response in the body. Another modality, which may be where Annie Hopper got her stuff from, is Gupta, the Gupta protocol, which is something that you do on a daily basis over 6 months. And I've definitely had people say this has really helped them if they're willing to stick with it. But I haven't had that in PANS patients. I haven't had that clinical experience.
Okay, thank you. This question is from Lisa. What about Dupexent? I'm not familiar with that.
Dupexent rings a bell, and I can't place it. So I'm sorry, Lisa. I just don't. Like I said, it rings a bell, and I can't place it.
Okay. You have the next one, Jody? Okay.
I do. This one is from Kim. She recently moved to New Jersey. Do you have any colleagues that you could recommend in that area or surrounding areas? She's in need of a LLMD who is experienced in neural Lyme and also hormone adrenal imbalances.
The person that I would highly recommend is Christine Jedrowick, Gedroic, but I don't know if Christine's taking any new patients. There are a bunch of other doctors in New Jersey, but I don't know them personally to be able to recommend them. You know, iLads, you know, you can go on their website and put your area code in and or zip code probably, and they can connect you with doctors in that radius vicinity. Unfortunately, you know, not all Lyme doctors are great doctors either. You know, it's, you know, just like other mainstream doctors, you know, there's the whole gamut.
Thank you. I have a question of my own, actually. Being a mom of a child with PANS and being an adult likely with MANS, is there another good test in addition to the Cunningham panel? I know that one can be cost prohibitive for parents or individuals. Are there other markers, other labs that offer some of the similar tracking for PANS or MANS?
Well, Vibrant Labs has a profile called Neural Zoomer. I don't have enough experience with Vibrant Labs to have full confidence in them. And they do not do the CAMK2 activity, but they do the other antineuronal antibodies. Mm-hmm. So that they do for $200, and that's an option.
Okay, thank you. Let me see. Okay, there's a follow-up on the Dupexent. It's an monoclonal antibody blocking interleukin 4 and 13, if that helps.
Yeah. Thank you. Thank you for that. I don't have experience with it. I don't know.
Okay. I am seeing, I know patients are looking for physicians from all over the country. iLads does have a physician referral system. Lyme Disease Association has a doctor referral system. LymeDisease.org has a doctor referral system as well. So no matter where you are in the country, those are systems that can cover you nationally.
All right, this one is from Amy, and she's saying, sorry if this has been covered. We have heard if Lyme stop and Rife machine, ? I did ask for clarification, but I think she's asking your thoughts on Rife and the treatment, I believe.
Okay, well, this is pretty interesting. For those of you who read the New York Times, Ross Douthat, who's a conservative columnist on their op-ed page, has written a series of articles on Lyme, and because he himself has chronic Lyme, and he just came out with a memoir of his experience that's just been released maybe this week. And the third article he posted on the op-ed page of the New York Times was in fact on his experience with the Rife machine, which is pretty ballsy, quite frankly, and because it's really alternative. And I wish he hadn't done it, to be honest, because if we're trying to give credibility to chronic Lyme in terms of what it is and what it does, that doesn't help. And, he's trying to give credibility to chronic Lyme. He's saying, hey, look, this is like chronic COVID, or long COVID, which is getting credibility. And, but chronic Lyme does the same thing. Well, I agree. On the other hand, if you start publishing that you're doing something like Rife machine, it's not going to help make that case. That said, between you and me, I've seen the Rife machine really help people. And, it can cause Herxheimer reactions at the right frequencies, and then people get better. It has to be done carefully because of the Herxheimer reactions. Probably shouldn't be done very often, every week at most. I know some people were doing it like daily, bad idea. I can talk for a while. I do describe it in my book as an alternative therapy. The great thing about it is you can do it at home, and you buy a box, and there are whole different setups for how it's done. But I think that it's a reasonable thing to add to the interventions to actually help with treating this.
Okay, we have another couple questions I'm going to combine from Ken and Rachel. Have IV drips with ozone and high dose vitamin C helped? Thoughts on use of far infrared saunas and coffee enemas for helping with PANS or Lyme or both? I'm not clarifying here.
Okay, so to start off with saunas, I really like saunas, and they help. Infrared saunas, just the infrared will mobilize toxins. In fact, can mobilize them so quickly that it can mobilize them quicker out of the tissues into the bloodstream than our bodies can eliminate them from the bloodstream, excrete them, through the liver and through the kidneys and through our sweat. So I recommend saunas to people, and I tell them to start slowly and build up, maybe just twice a week at lower temperatures and lower times, and slowly build up to, for most people, maybe up to 130, 135 degrees for 30 minutes, up to 3 times a week. People should be getting detox support when they do that, and obviously drinking fluids and electrolytes. Always shower right afterwards, because even if you don't sweat, those toxins are on the surface. You really want to get rid of them before they're reabsorbed. So I think saunas are really great. Intravenous vitamin C, I've mainly seen it people who have viral activation. I haven't seen it help just plain Lyme that much. I do see intravenous glutathione often helping. It's great in terms of it's helping with detoxification, as an antioxidant against free radicals and so on. And then was there a third part to that, Monica?
Let's see. It was infrared saunas, coffee enemas, ozone, and high dose vitamin C.
Okay, so ozone, I've definitely seen benefits with ozone. Again, I discussed these in my book. Ozone, particularly tied with ultraviolet blood irradiation, so that when the blood is taken out, it goes through a chamber where it's exposed to certain ultraviolet light frequencies, and then is pulled up in a syringe, then puts in the ozone, and then it goes back through the chamber into the body. And I've definitely seen that help people, sometimes quite a bit. That said, there is now, over the past few years, and I don't have this in the book, something called 10-pass ozone, where instead of taking out maybe 60 cc's of blood, it takes out like 200 cc's of blood, and goes back and forth up to 10 times. And I've talked to a couple doctors who are doing this in the office, and they feel that it's much more effective than the regular IV ozone. There is a doctor here, the Sound Clinic, who does that in Denver. And but again, I think it needs to be started somewhat slowly because of the potential for Herxheimer reactions. And then finally, coffee enemas. I really don't have that much experience with it. I know I have patients who do coffee enemas and feel that it's really beneficial. The coffee allegedly stimulates the liver to be detoxing more and then evacuating all sorts of toxins. I don't have much clinical experience with it.
Monica, could you go ahead and go through two, because we have a couple questions on this. Just go ahead and state the webs for CODA, right? Where people can go there and how they link to this Lyme group. And then also, could you list out one more time the three? You mentioned LymeDisease.org for doctor referrals, ILADS, and then there was one more. So could you just state that one more time for everybody? There's people that are just wanting clarification on that.
Absolutely. Yeah, we want to make sure everybody has the resources. LymeDisease.org, ILADS, as well as Lyme Disease Association have national doctor referral databases that people can query. Yep, Global Lyme Alliance also has doctor referrals. Thank you, Gloria. In addition, the Colorado Tick-Borne Disease Awareness Association is located at coloradotix.org, and that is a resource for finding access to support groups, doctor referrals, tick testing, you name it. There's a whole slew of resources there, but you can ask to join the private patient Facebook group, which is Colorado Lyme and TBD Patient Support Group. That one is private and isn't accessible or viewable when you do a search. You have to ask for an invitation. We do that to protect patients because it's a very private space.
I'm going to go ahead and put my email in chat for that. And if anybody wants invited from this meeting to that group, I'm a co-administrator on that. Please just email directly with your email address and I will get you connected.
Yeah, and with that too, so the Colorado Tick-Borne Disease Awareness Association Facebook group is an open public group. You can ask questions there, but it's not a private space. Colorado Lyme and TBD Patient Support Group is a private space for that interaction, where you can ask very, very candid questions or share private information, and it's in a safe space. And again, the links to all these other resources are on the Colorado Tick-Borne Disease Awareness webpage. Let me see. I think there was another question right before we did that. Debbie has a question about your thoughts on disulfiram, and I know we were fortunate to have you do a presentation on disulfiram as well. So maybe we can get a link to that presentation, Jody, as well. But if you could answer, what approach do you take if some symptoms begin to relapse, Dr. Kinderlehr?
I'm wondering, I'm wondering what the context of that question is. Is Debbie asking what happens to people who were on disulfiram and did well, but now are off of it and symptoms are relapsing?
What approach do you take if symptoms begin to relapse? Debbie, do you want to clarify on that? And we can re-ask. And in the meantime, Dr. K, do you think that PANDAS, once stopped, can get triggered again later in life?
Well, you know, I haven't seen data on this, but I highly suspect that it can. We're talking about a population of people that are genetically predisposed in whom we're suppressing microbial infection, but we really don't know if we're eradicating it. We do know that when we're treating chronic Lyme, which really, I would like to use the terminology Lyme disease complex because it's a whole lot more than just Lyme, that these people are prone to relapses if, they're exposed to a whole host of things, from head trauma to surgery to emotional stress to mold to viruses. I mean, so my suspicion is that the PANS can recur as well.
Okay. Jody, I see that Debbie responded. So disulfiram overall, Dr. Kinderlair. And yes, if you stop the med and then some symptoms return, what are your thoughts on that?
Well, disulfiram is really tricky. I've gone from recommending it to a whole lot of people to being really careful with it because it's so unpredictable. Some people have done just marvelously on it, and then some people don't tolerate it at all, and then there are people in the middle. I would say that if someone has been on disulfiram and does well, but then after stopping it starts to have symptoms again, usually I'll put them on botanicals at that point. I've frequently had the experience of trying to put them back on disulfiram, and they don't tolerate the doses that they used to tolerate. So we have to be really careful when we put them back on disulfiram, which I have done in some cases, but usually I'll try to go with some other modality first. I'll just point out that our biggest successes are people with Lyme and Babesia. It seems to hit, it definitely hits Bartonella, but doesn't seem to do as good a job. And it simply doesn't do as good a job when people have 3 infections instead of 2. So that's, par for the course in our clinical experience anyway. So, typically, if they did really great on disulfiram, we will try that again, but I'll be more careful in terms of not necessarily putting them back on what had been their most effective dose. Typically, we'll use lower doses, and depending on how comfortable they were on the disulfiram or uncomfortable, we won't put them back on disulfiram. We'll try to not put them on antibiotics, see if we can get away with botanicals.
This one's from Amy. How important is it to get rid of or move out of mold? What percentage of patients improve by getting rid of mold?
Well, I wish I could give you numbers on this. It's so individualized. Just mold is a huge, huge problem. And it's interesting, for example, I'll see someone with Lyme disease and I say, hey, you got to get your house checked. I really think there's a mold problem. And there is a mold problem, but the other members of the household who don't have Lyme disease, they're not symptomatic from it. The person with Lyme disease is symptomatic from it. Again, when you get these infections, you develop these hypersensitivity conditions. And at that point, getting away from it is really, really important. But I can't give you percentages. There's some people in whom it's just dramatic. Getting away from it, it makes a big difference. Sometimes when we're not sure what's going on, I'll ask people, is there somewhere you can go for 2 weeks, be out of the house, and, in what you strongly believe is a clean environment before you go back. And sometimes that tells everything. They go back and it's like, oh my God, migraine started day 1. But it's again, an individual basis. I can't give you statistics.
There's a question from Gloria. What are your thoughts on effectiveness of dapsone? And I'm not sure if this is in relation to PANS treatment or in general to Lyme treatment.
Yeah, so I'll just go on record. I've never used dapsone and really don't intend to. It has a lot of side effects that are not clear from the literature that's come out of the Horowitz camp. I know that some people have gotten better on it, but I also know that there have been a ton of side effects, and that his double dapsone therapy is really I would call it heroic. You know, this is something that one might consider as a last ditch something, but I'm just not comfortable with that drug used in the way that it's been used for Lyme disease.
What botanicals do you find most effective?
Well, I really like Nutrimetics, Cemento, Banderol, Noni. Cemento mainly hits Lyme, Banderol mainly hits Bartonella. I always start things one at a time. The Byron White remedies tend to be much stronger and therefore often not tolerated. Like these are extracts where sometimes one drop really sends someone spiraling with a Herxheimer reaction. But they seem to be very, very powerful for people who tolerate them well. So I use those a lot. For people who are more sensitive, I'll use beyond balance remedies like MCBB1, MCBAR1, MCBAB1. I like resveratrol for Bartonella. Seems to be good. BLT from Research Nutritional stands for Bartonella Lyme treatment. It really hits Bartonella well because sometimes some people have a really significant Herxheimer reaction at low doses, Bartonella Herxheimer reactions. And it's always a question of trial and error and always going slowly, always one at a time. And I'll just point out that it would seem obvious that people would tolerate these natural herbs much better than they would the pharmaceutical antibiotics. It's not always true. I have quite a few patients who don't tolerate the herbs whatsoever and who do just fine on the antibiotics. And of course, there's some people who, can't do antibiotics and they're okay on the herbs. Ideally, I have people on both. I think that people do best if we can hit the bugs from different directions and have them on both antibiotics and on herbs. Again, I do discuss all of these in more detail in the book and would recommend that.
Okay. Unless I missed, I am not seeing additional questions, Jody.
One just came up. Monica.
Okay. Oh, yep, there it is.
Last one. There we go. Sliding in on the end there.
Okay, Amber, I'm considering a potential move to Atlanta in the coming year, and I'm trying to weigh the benefits of the lower altitude with the higher risk of mold due to the higher humid environment, Colorado, with higher altitude but drier air. Would you have any recommendations on location for someone with Lyme, tick-borne relapsing fever, Babesia, Bartonella, and mold toxicity? Where's the best place in the country to live?
Yeah, I'll tell
We
you
all
where.
want to know.
Yeah. Although I think we're here.
Inquiring people want to know. I'll tell you where. New Mexico.
Oh.
Yeah, New Mexico. It's much drier than Colorado. People say, "Oh, Colorado's dry." Nothing compared to New Mexico. At least when I lived there. I mean, it was so dry. You could get out of a shower, dry yourself off. So you'd have a really wet towel. Well, in 10 minutes, that towel would be bone dry. It was much, much drier than it is here. And remember, there are mold spores everywhere. That's the case everywhere. But if they get trapped in a place with some moisture, then you're going to have mold growth. That can happen in New Mexico as well. As we were mentioning earlier, there's a lot of mold here in Colorado. I mean, and actually, and this is in my book in a footnote, that a patient, I remember told me about this and I looked it up. She claims that there are more mold problems here in the Southwest than there are in higher humid areas because the building standards are not as strong. And so, all that happens is you get a leak behind a wall and you can have a major mold problem and not know it for years, which I've seen happen, like to my daughter, for example. It was a catastrophe. And so, no, nowhere is safe, but, New Mexico, I think, it's the least likely place to get a tick bite. or I shouldn't say a tick bite, but least likely place to get Lyme disease. You can get Lyme there. When I lived in New Mexico for about 7 years, I saw maybe 5 patients who had gotten Lyme disease there. Colorado, I've seen tons more of people who've gotten it in Colorado. I've even seen more who've gotten it in Arizona. Maybe it's because they water their lawns there. I don't know. But New Mexico is where I go, and I wouldn't be afraid of Atlanta because of the humidity aspect. I really wouldn't. I definitely have patients who don't do well at altitude, and some of them, we have them on oxygen at night because it really helps to keep them balanced. It definitely is a problem. I have a lot of patients who are okay in Denver or Boulder, which is 5,000 feet, but they go up to Vail or Aspen, they're not happy campers whatsoever. So, I wouldn't be afraid of Atlanta for the mold reason. You're going to have to do your due diligence looking for mold wherever you live.
There is also a comment from an individual that says that she's seen the showers in Colorado more moldy than in Florida. So
Very interesting.
yeah.
And Lynn,
Yeah, I was just going to say, if you could say the name of the book, that would be great.
Absolutely. So Dr. Candelara's book, as I stated before, it's an incredible resource, and it's Recovery from Lyme Disease, the Integrative Medicine Guide to Diagnosing and Treating Tick-Borne Illness. And the other book that Dr. Candelara mentioned, I'm just going to grab it real quick. This one is by Dr. Kenneth Bach, and it's Brain Inflamed. And again, both books filled with resources for individuals or parents, especially for kids, trying to figure out what's going on and how best to approach things. Both of these books are incredible resources. I got through both of them very quickly because they're written very well. Thank you.
I think that is all of our questions.
Okay.
I want to thank everybody for joining us, and a special thanks to you, Dr. Candelara. Again, you have just been a wealth of knowledge and information for our community, and continue to be extremely supportive for each individual and taking the time to present through our groups. We really, really appreciate it.
You're very welcome. Thanks for hosting this. Thanks for taking this on. What you do to support the community is so much appreciated.
Yeah, well, we can't wait to have you back again on another topic or on a follow-up to the topics you've covered. We're so appreciative. And really appreciative to our community partners too that allow us to do this. We had a great turnout today. And so Dr. Candelara, the work that you're doing, people are wanting to hear it. So thank you for doing what you do.
Yes. And as a reminder, everybody, this is recorded. I will be posting this after the holidays. And you will see it through Meetup. We will post it on Meetup. It will also be posted if you are a member of the support group that Monica had mentioned, the Lyme group. We will be posting it there as well.
And then all other resources, coloradotix.org is where you can find Colorado Tick-Borne Disease Awareness Association. And there's links to all of these things. So.
And as always, if you have any questions, comments, or concerns accessing any of the information that we're providing you, you may email me directly, or you can find me up on Meetup as you found this presentation today.
All right. Thank you, everyone.
Thank you, everybody. Be well, be safe, and happy holidays.
Thank you.